So welcome everybody to this symposium, Hologic Symposium. As you know, we as surgeons, especially in hysteroscopy, we like to have new toys. And companies, they bring us many toys. And one of the companies that are bringing a lot of innovation in hysteroscopy is Hologic. So first, I would like to give the microphone to Rachel Williams. She will give some words about the company. Rachel, it's yours.
Thank you, Professor Hamovich. Hello, everybody. My name is Rachel Williams. I am the Scientific Affairs Manager for Hologic, Gynecology and Perinatal in the EMEAC region, which is Europe, Middle East, South Africa, and Canada. I'm delighted to be here today. Hologic are an innovative medical technology company. We work very hard in partnership both with yourselves and also with important societies and groups such as GCH. So we're very pleased to be with you today. We're very committed to women's health. The majority of the company is focused on that, both in diagnostics, surgical, as I've said, perinatal, and also breast and skeletal health. And also we like to work with yourselves on unmet needs within gynecology, and especially in the minimally invasive space. A lot of our design, R&D, and technology is as a direct result of some of the names I see here from some of our innovation advisory boards and summits. And we're really honored to be part of this virtual meeting. A shame we're not in sunny Barcelona. And it's very important to us to constantly learn innovative techniques and also to trial our new innovations with yourselves. So this is why we've asked Mr. Athanasius to share his experiences with some of our new technology today. And we are very committed to GCH and to continuing that development and also the training alongside. So thank you for your opportunity today.
Thank you, Rachel. So I will now, it's an honor and a real pleasure to introduce Dr. Pandelis Athanasias. He's a consultant gynecologist in London and an expert in hysteroscopy procedures, and in particular in operative office hysteroscopy. So Dr. Athanasias, the microphone is yours.
Thank you, Sergio. And we will talk about optimizing outpatient hysteroscopic procedures that are quite popular, becoming very popular in the UK. And we can start the presentation and then answer any questions. I am Pandelis Athanasias, and I'm a consultant gynecologist at Epsom and St Helier University Hospitals in London. And today we'll talk about optimizing operative outpatient hysteroscopic procedures. A few things about our unit. We started 10 years ago by performing diagnostic hysteroscopies, and then gradually we expanded, and we nowadays perform hysteroscopic polypectomies of any size polyps, myomectomies of type 0 and type 1 fibroids, endometrial ablations, treatment of Asherman's, removal of adenomyotic lesions, and it's remarkable the significant increase in the number of procedures for removal of retained products of conception. And this includes patients after an incomplete miscarriage, after vaginal birth, but even after cesarean sections. For operative hysteroscopies, we started using the Classic and the XL operative scopes from Hologic. The Classic was 6.25 millimeters wide, and the XL 7.25 millimeters. Classic better for polyps, the XL ideal for fibroids. Then we moved to the Omniscopes, which came to the market a couple of years ago. What is the difference? Omniscopes can allow you to see and treat, have the diagnostic and the operative sheath on the same set, and the operative sheath, it's narrow. It's 5.5 and 6 millimeters, as opposed to 6.25 and 7.25 millimeters. To remove the polyps and to remove the pathology, we use the MyoSure tissue removal system. I have been using MyoSure for many years now, and as you can see, you can use the manual or the light for polyps. You can use the reeds for polyps up to 5 centimeters or small fibroids up to 3 centimeters, and you can use the XL for fibroids up to 5 centimeters. It is fantastic that you can remove a 5 centimeter fibroid in less than 15 minutes. The new arrival from Hologic is the 30-degree omniscope that allows better visualization of the ostia and the side walls. I have to admit, this is brand new. I never used it, but I am quite happy with the 0-degree scopes. I know that in the States, 0 degrees are more prevalent. In Europe, we tend to prefer the 30-degree scopes, but I think it's down to every surgeon's preferences. Why we need to talk about optimizing the operative outpatient hysteroscopy procedures? This is because we perform now more advanced procedures, and we perform procedures on medically challenging patients. So how can we optimize our practice? We need to invest in technology. So we need advanced hysteroscopes and advanced fluid management systems, and we need to concentrate on pain relief, because inevitably more advanced, more complicated procedures will last longer. Technology. I used the new omniscope. We purchased the omniscopes a few months ago in our unit. And what are the advantages? As I mentioned earlier, all in one scope. So you can see and treat at the same time. You don't need to open a separate hysteroscopy set, so you save money. And these new scopes are smaller. So I can remove polyps with a 5.5 millimeter sheath, and I can remove fibroids with a Myosure XL device with a 6 millimeter operative sheath. Also, new technology, much better. I would call it superb visualization. What about the tissue removal systems? I mainly use the Light, the Reach, and the Myosure XL. We remove polyps of any size, and we remove fibroids, again, type 0 and type 1, up to 5 centimeters. We know that fibroids up to, especially type 1, larger than 3 centimeters, you might need a second stage procedure, but this is to be anticipated. We inform the patient in advance. We also have an increased clientele of patients requiring removal of retained products of conception. What other advantages of the omniscopes? They reduce the duration of the procedure, probably because you have to dilate less, and the visualization is much better. You can either perform vaginoscopic operative hysteroscopy, because the sheath can be either 5.5 or 6 millimeter, and they are ideal for one-stop clinics because it saves so much time that otherwise you have to spend in order to operate another separate hysteroscopy set and set up everything from scratch. When it comes to the analgesia requirements, nowadays, the advanced hysteroscopic procedures carry advantages and disadvantages. What are the pros? Smaller scopes, better visualization, advanced tissue removal systems. It means the operation shouldn't last so long, so the analgesia requirements decrease. At the same time, we perform more challenging procedures that we wouldn't even thought of performing 10 years ago. We remove large fibroids, as I said, type 0 and type 1. We remove calcified retained products of conception that are really adhered into the endometrial cavity. And those procedures will last longer. Also, we have to deal with medically complicated patients with many contraindications, many allergies, and our pain relief options can be limited. What are the options anyway? We can use non-steroidal anti-inflammatory drugs like ibuprofen or diclofenac, opioids, paracetamol, intracervical or paracervical block of local anesthetic, local anesthetics via topical or intrauterine route, and nitrous oxide, also known as Entonox. What is our choice? If we need to be based on evidence, and we know that non-steroidal anti-inflammatory drugs are very efficient post-operatively. So we use ibuprofen 400 milligrams up to an hour before the procedure. I also use 1 gram of paracetamol up to an hour before the procedure, intracervical and paracervical block. So I inject lignospam intracervically and then 2 more ampoules paracervically. We know that this regime is very efficient intraoperatively, and I also use Instillogel. This is proved to be very efficient with cervical dilatation. What is Instillogel? Local anesthetic, lidocaine, and chlorhexidine. And if you apply it a few minutes before the dilatation, it makes a massive difference. On our audit, we found out a few years ago that during the operative hysteroscopic procedures, most of our patients were very uncomfortable during the dilatation of the cervix. By using Instillogel and leave some time to make a difference, the pain scores reduced dramatically during dilatation. So nowadays, we treat type 1 submucosal fibroids, like the pathology on the left, retain products of conception that can be really adhered to the endometrium, or retain the products of conception that almost obliterated the endometrial cavity. Fluid management in operative hysteroscopy. This is one of my passions because this was something or an aspect of the outpatient service that we neglected in years. And now that we perform more complicated procedures, it's a hot topic. What we need to be very familiar when we talk about fluid management in operative hysteroscopy, the distending medium we use, how important to control the deficit is. If we have to use an advanced fluid management system for every procedure, if it's worth investing a very expensive fluid management system, and what is our experience so far? There are general rules that apply to any hysteroscopic procedures regarding fluid management, whether they are performed at the general or local anesthetic with isotonic or non-isotonic media, but are guidelines more relevant to the operative hysteroscopic procedures with the tissue removal devices that we are talking about today. ESG and BSG came with a very detailed, comprehensive guideline that any clinician should be aware of. What it says, continuous measure the fluid deficit. So we need real-time fluid deficit alerts. When we reach a certain threshold, the inflow should stop automatically, and the fluid management system should be able to measure and titrate the intrauterine pressure of the fluid in order to achieve the best visualization. When we perform outpatient procedures, we use normal saline with a MyoSure or any other tissue removal system. And we know with normal saline, we can go up to 2.5 liters of deficit, but never forget, always be aware that medically complicated patients, like patients with renal impairment, cardiovascular disease, elderly patients, the threshold is 1.5 liters, not 2.5 liters. What are the office outpatient hysteroscopy advantages? Shorter times, smaller scopes. We use normal saline and not glycine, so less chances to cause complication with a high fluid deficit, but the fluid overload may still happen, may still occur. What are the challenges? As we talked earlier, really complicated and advanced procedures, myomectomies, removal of retained products, gain popularity, and those procedures include lesions of high vascularity. We tend to deal elderly and patients with comorbidities, especially during the COVID pandemic. All those patients were directed to the outpatient department. And never forget that when you perform the procedures in the office or in a small community hospital, you don't have the multi-specialty support and the lab facilities to deal with a patient that developed TUR syndrome. Those are the principles of fluid management when it comes to outpatient operative hysteroscopic procedures. Monitor the fluid deficit closely. Maintain the lowest intrauterine fluid pressure to achieve the best visualization, and terminate the procedure at a lower threshold of fluid deficit when you don't have the facilities and the expertise to deal with the complications. Aqualix is the fluid management system from Hologic that's been around for many years. Fluent is a new fluid management system from Hologic that we used the last 12 months. It's very easy to set up. It has a touch screen. According to Hologic, apart from easy to set up, it's very easy to operate. No multiple canister, no complicated connections, and provides advanced pressure control. What does this mean? Well, it means that with less fluid, you can achieve better visualization, and you can maintain the intrauterine distension, consuming smaller amounts of normal saline. And according to the research from Hologic and the graphs, you can see how the fluid also can maintain a consistent pressure within the cavity. This way, the procedures don't last very long. According to Hologic, more than 80 to 90% of the gynecologists and nurses thought that the new system, it's much more efficient compared to the old fluid management system. And why? Because it provides advanced control of the blood, of the intrauterine pressure. And we know that high intrauterine pressure, in order to achieve better visualization, means higher deficits. Duration of surgery, as I mentioned, because of the better controls, it reduces the time we need to perform a challenging procedure. What is our experience? We used it in 40 cases, and we actually found out that all our procedures, or most of our procedures, last 7 minutes less in average. No clinician had to increase the pressure about 80 millimeters of mercury, very important, and we used less normal saline. We do a continuous audit of the pain scores, and that demonstrated on those 40 cases the significant reduction in the pain during the procedure. This is the European experience from using Fluent the last few months, and you can see more than 80 or 90% of the gynecologists thinks it's very easy to set it up. You minimize the use of fluid, increases the speed of the procedure, and you can see really well when you perform the procedure. So, do we need an advanced fluid management system? Or do we need for every outpatient hysteroscopic operative procedure? I think it's essential when we remove large polyps, fibroids, retained products of conception, and adenomyotic lesions. For small polyps that the operation won't last more than a few minutes, we don't need to spend the additional money for the disposables, and we can escape with a simple setup. A very advanced fluid management system like Fluent, though, increases the clinic capacity. For us, we can see an additional patient in order to assess, perform the diagnostic and the operative procedure compared to when we use the Aqualix, the old management system. And as I always say, a fluid management system, no matter how advanced it is, it's not everything. You need to be very well aware of the ESG and BSG guidelines, because you will be the one who will operate the fluid management system. And to conclude, the fluid management system is a game changer as it provides excellent visualization. It reduces the amount of time we need to perform the outpatient procedures, and it has a very easy setup, and it's very easy to operate, and it reduces the anxiety of the medical and the nursing staff dealing with a complicated device. Combination of the Fluent with the Omniscopes increase the capacity of our one-stop clinics, as we can see, treat the patient at the same time, and the procedures last, as I mentioned earlier, 7 minutes less in average. At the same time, technology can help us, can optimize our outpatient hysteroscopic clinics, but we need to continuously monitor the patient satisfaction, because this is what will guide us towards further advances. We have to keep up to date with new pain relief options, and last but not least, all the medical and nursing staff should be familiar with the equipment we use, with our guidelines and protocols, and they should be able to troubleshoot and provide care when we have to deal with unexpected issues. Thank you very much.
Thank you very much, Pandelis. You know, we don't have much time, so I want to be very clear with my questions to you. You know that most of the OBGYNs, they still perform resectoscopy in operating room. Most of them, you know, when we asked the poll here, it was majority. So when people are thinking about moving into office and they have to buy new capital equipment, and you know they have to think very well about the invest they're going to do. What do you think that maybe this Omni platform of Hologic, maybe it can be the most adequate equipment for doing this movement from operating room into office?
I think, and I'm talking from experience from our unit, we initially used the MyoSure device and the new scopes in theater. The clinicians became skilled, and then we moved to the outpatient department. And the basic advantage was that we use smaller scopes, so less need to dilate the cervix more than 6 millimeters. Then we use the advanced fluid management system in order to proceed to operate on medically complicated patients, especially for fibroids. I have to admit, not so much for polyps, but fibroids and retained products of conception that can take longer to operate. And at the same time, it's the constant support from the company in order to troubleshoot with the new equipment made the massive difference. So now the vast majority of our patients are having proper one-stop, genuine one-stop appointments where we see them, scan them, perform the diagnostic, and then move to the operative hysteroscopy.
So if I understood well, the Omni platform starts with 3-point-something millimeters. No,
3.7 millimeter is the diagnostic. Obviously, it's wider than the routine diagnostic hysteroscopy. So the diagnostic hysteroscopes we used in the past that were less than 3 millimeters. So what we prefer is, because we're going to scan the patient, if we are quite confident that there is pathology, we open the Omni set. If we think that it's unlikely that we're going to find pathology, we use the 2.7 millimeter scopes.
But I'm not sure that most of the people here use the system that you were used to use, that was less than 3 millimeters. As I know from what we asked, most of the most used hysteroscope for diagnostic and see and treat purposes is Betoki. It might be 4 millimeters or 5 millimeters. So the Omni platform, being less than 4 millimeters, is a good option for diagnostic. And if I understood well, you can convert it in the see and treat option at the same time.
Yeah, exactly. You just change the sheath, so you don't have to open a new hysteroscopy set. So it's you save time during the procedure, and at the same time, as to perform an operative procedure, advanced operative procedure with a sheath of 5.5 millimeters, or to dilate up to 5 maybe, it makes a massive difference. To me, because we perform now advanced operative hysteroscopic procedures, and as you mentioned earlier, you should not force anyone to have the procedure in the outpatient. The patient should be comfortable, and I think that any procedure that lasts more than 20 minutes operative time in the outpatient, there's no point to even attempt it. So I think with the new scopes, smaller dilatation up to 5 or 6 millimeters, procedures that would never take us more than 15 or 20 minutes to perform, made a massive difference and became acceptable to most of our patients.
And another question, I think, is the last one, looking at the time. You know that we are now going into a new era of not more blind procedures, you know, that everything must be performed under direct vision. And we are kind of against DNC because it's a blind procedure. So what do you think are the advantages of the MyoSure platform in this case?
I think, and I totally agree, blind procedures do not belong to our time. So we have the facilities nowadays to take direct biopsies, to always remove polyps under direct vision. And for example, in our unit, we banned every blind procedure, even especially to remove polyps with polyp forceps, whether that's in theater or in the outpatient department. And I know that there's a huge drive, even from this hysteroscopic society, to perform direct biopsies with tissue removal systems because they're more accurate. And I think as there is evidence that presented in this or other conferences that eventually you save money because you don't have to repeat hysteroscopy or the procedure when you get an inadequate specimen. So I think those new tissue removal systems, whether it's MyoSure or a different one, will be the norm, will be the routine practice, even taking biopsies in the future.
Okay, thank you. And for finalizing, I want to just to add a small thing that at the beginning, we teach people how to perform diagnostic hysteroscopy, just to go into the cavity and to look at the cavity and feel comfortable by doing this without anesthesia. And very fast, people, they see a small polyp and would like to go and start doing surgery. This platform allows you to use what I call the MyoSure manual, and you can go through the working channel without doing anything else and just to remove small polyps. It's a great tool so for the beginners also. So Pandelis, thank you very much. I want to thank, of course, Hologic for the support giving to this Congress and to the GCH. And it was a great symposium and great to having all you here. So right now I give the microphone directly to Luis and we continue with the Congress. Thank you very much.
Thanks, Sergio.